Okay, good morning, everybody. Thank you so much for joining us today for the second IARC Caribbean Cancer Registry Hub webinar. For those of you who are new to the webinar series, the Hub is doing a series of webinars on topics that we think are pertinent to you in the work that you're doing at Caribbean Cancer Registries in an effort to build a stronger network within our Caribbean Cancer Registries, but also to share information that we hope is useful and informative and helps you with your day-to-day work. So for those of you that don't know me, my name is Sarah Cannell-Crooks. I think everybody on the call does know me. And I'm the program coordinator for the IARC Caribbean Cancer Registry Hub. And it's a pleasure to be here, and I'm so happy that you were all able to join us. I know we're getting into the Christmas season, and with this comes a lot of other activities. So we're so pleased and thankful that you're able to join us. And we think that this is going to be a very informative webinar for you. So without any further ado, I'm going to go ahead and introduce. I'm going to stop sharing, Stephanie, so that you can share your slide set. I'm going to go ahead and introduce Stephanie Hill, who is our main presenter today. Stephanie is a certified tumor registrar with 20 years of experience in hospital and central cancer registries. Prior to assuming her current role as Associate Director of the North American Association of Central Cancer Registries, which most of you are probably familiar with, NAACCR. They've been a partner of our hub for the past 5 years. And Stephanie is the Associate Director. She has served as the Program Manager, for the New Jersey State Cancer Registry before she joined NAACCR. Stephanie holds a Master's of Public Health degree from Johns Hopkins University and is a Lean Six Sigma Green Belt with a focus on process improvement. I will admit, Stephanie, I'm not sure what a Lean Six Sigma Green Belt is. So I'm wondering if you could tell us a little bit more about that. But we welcome Stephanie. We're so happy that she's here to present on standard operating procedures in cancer registration. She has a wealth of experience, and we are very pleased to invite her to present today. So over to you, Stephanie.
Hi, Sarah. Thank you very much for that introduction, and I'm just so excited to be here. I've been enjoying the music. It makes me feel like maybe it's not quite as cold outside as it really is here. But that's a happy delusion I can have. I am happy to talk at length at another time about Lean Six Sigma. It is it's an approach to process improvement that was initiated in manufacturing, but it's been widely adopted in healthcare, and which is my background in it, is from my days in the hospital, looking at ways that we can improve patient care, and they really rely very heavily on data, which is why we're hoping to adapt it to process improvement in the cancer registry, because we do have so much data. But that is a topic for another time. Today, we're here to talk about the Data Collection and Operating Procedure Manual for the Caribbean Registry Manual. So I like to start off, with this graphic, this thought, and because it's why we're all really here, right? We want to make every case count, and we want to count every case. That is the mission that we in the cancer surveillance community and the cancer registry are charged with. That is why we do what we do, right? So I always try to keep that in mind as the foundation for everything that we do and that we're asked to do. Standardization, which is what this manual really is all about. And why is standardization important? It's a lot of work to develop these standards, a lot of people, a lot of agencies, all of you put work into developing these standards, and then to making sure that we follow the standards. And excuse me, I'm sorry, Sarah, can you see, I meant to ask, can you see my appropriate screen?
Yes, we're seeing and hearing perfect.
Great, thank you. So, it's a great deal of work. why do we bother? Why can't we all just do what works for each of us and be happy with that? And the answer is comparability. We want to be able to compare cancer rates across registries, whether that's across states or across countries. And when we compare, we want to make sure that we're comparing, as they say, apples to apples and not apples to oranges. So in order for the data to be comparable, we need to make sure that they're being collected in the same way. That means collecting the same cancers for the same patients, and that the data themselves are being coded and collected consistently from one registry to another. So we have to have standards that address who is included in the registry, that is who the patients are, and which registry is responsible for collecting which patients. And that's why we document residency, and we try to be so careful about documenting residency at the time of incidence or diagnosis, because we need to make sure that we're covering all of our reporting sources, all of our case finding sources, to just make sure that we are capturing as many as of the cancer cases as we can, obviously with a goal of collecting 100% or as close as we can get. And that's also why case sharing is really important, so that we can compare registries and be confident that each registry has counted all of their cases. If we're not confident that a registry has captured all of its cases for its residents, it makes comparing data and incidents across boundaries really difficult. And then we also need standards that address how the data are collected. And we do that by defining what cancers are registered. We do that by defining an incident case. We're very careful to define what is meant by an incident case. We have reportability rules and case finding lists that define what ambiguous terminology constitutes a diagnosis. And then we have multiple primary rules that we need to follow in order to make sure that we are doing what we said. We're counting every case. When registries don't follow these standards, their cancer rates may appear higher or lower than when they're compared to other registries. And then, of course, we have coding standards that tell us how the information is to be documented in the abstract, and those will be discussed in a future workshop. So here we're really going to talk about the first chapter of the manual. And I just want to start off with a little bit of background. The manual obviously was developed from a need to have consistent standards. This need was actually identified more than 4 years ago at a workshop in Turks and Caicos. I believe there were more than a dozen Caribbean countries represented at this workshop. And they decided that a modular approach would really be appropriate. So they identified these 6 modules to be addressed for standardization. They included data collection, establishing a registry, quality control, generating reports, data analysis, and a research guide. We are really focused on the data collection module at this point. So the first draft, the very rough draft, was compiled by NAACCR, and they looked at other manuals that were in existence at the time. We always like to look for best practices or standard practices that we know have been tried and tested in other places. So they incorporated content from the standard procedure for population-based cancer registry in sub-Saharan Africa, the manual of standards for cancer registration in the Middle East Cancer Consortium, and the program manual from the New Jersey State Cancer Registry, which, although I was not a part of NAACCR at the time when this was done, I was at the New Jersey Registry, so I might be a little bit biased, but I like to think that it's a pretty comprehensive manual. that New Jersey works from. So just very quickly, going through the timeline, as we said, NAACCR developed that first rough draft in 2016. And then the next year and a half was really focused on getting feedback and input from all of you, from the stakeholders, from the registries, because they really wanted this to be a stakeholder-driven initiative. And so there were multiple opportunities when they requested feedback. They presented the manual at these events, and they incorporated feedback from the registries. So what they got was an iterative process involving expert guidance and Caribbean, regional, and international stakeholder participation. So I want to go over just do an overview of the content of the manual. And it's really important to note, you'll see on page 4, Roman numeral 4 of the sort of the front matter of the manual, that you can use this manual and any content from it for your own registry's use. We ask that you acknowledge the manual as the source, but it's meant for your use, so you don't have to worry about copyright infringement. This is yours for your use. The table of contents, very quickly, there are 3 key areas to the manual: the overview, the process standards, and the abstracting and coding. In this webinar today, we will be talking about the overview section as well as the first 3 appendices. And the next webinar, I think, will focus on the other sections. So we start off the manual with a definition of cancer. This is probably not new to any of you, but it's important to note. We said in the beginning, it's important to make sure that we are all talking about the same thing when we talk about cancer. Defines a cancer registry, again, not unfamiliar to any of you at this point. But cancer registries, we need to stress, are really important public health tools. Cancer diagnosis. We said in the beginning, we need to make sure that we are counting every case, and that means making sure that we define what a cancer case is. So a cancer diagnosis is made by a medical professional, often a physician, and so we need to make sure that we're identifying the cancer diagnosis and the date. The date is really important when it comes to identifying what counts as a new or an incident case. And of course, we use this for calculating survival time, which is a really important outcome and use of cancer registry data. Most often, a physician or a pathologist will make a definitive statement about the patient's cancer diagnosis, but sometimes they don't. And these areas can be sort of a gray area when the physician is sort of, ambiguous and not really committing to a definitive diagnosis. And when they use ambiguous terminology, again, we want to make sure that we're all counting the same cases, that we're all following standard rules for when we count those ambiguous cases and when we don't. And that's why we have lists of ambiguous terminology and when we count those as a diagnosis and when we don't. Again, it comes down to counting every case in the same way. If your registry is collecting cases with a probable diagnosis and my registry is not counting them, my incidence rates are going to be lower. They're going to look lower than your registry, right? And that could be problematic when we try to compare our data to one another. It's really going to be misleading, which is what we don't want. And then most cancer diagnoses are based on pathologic examination of tissue, but some are made through radiologic imaging, clinical exam, or some other test results, such as a blood test. So when we do our case finding, we want to make sure that we're looking at all of these sources and not limiting ourselves to pathology. Because again, we might be missing cases and erroneously reducing our cancer incidence rates. The manual also addresses changes to diagnostic information. This can be important. We know that, any of us who have been through medical records, we know that things change. So for many of the individual data items, there are timing rules that are included. They tell you, to include information that was obtained during a certain period of time after diagnosis. So those are important to follow. But changes do happen, and they're legitimate changes. There may be missing or uncertain or non-specific information in the beginning that further workup reveals more specific or better information. And in those cases, it's really important that we make those updates so that we can count cases in a consistent manner. And these include things like primary site, histology, extent of disease, residency, etc. Sometimes additional information or re-examination of the record tells us that this case turned out to be not reportable when previously we thought it was. This tends to happen often when we use those ambiguous terminology. Initial imaging sometimes or clinical exam, the physician may feel that this is a probable carcinoma, and then later tissue examination reveals that it's not. And it's really important that we remove those because they are not cancer diagnoses, and they can cause confusion in the data when we try to analyze it. And again, when we compare it. The manual addresses case finding in section 1.5, and it defines two types of case finding, active and passive. Active case finding is very often and should be used in hospital and healthcare settings when they have access to the medical records. And that's when the cancer registry staff are actively reviewing the records and identifying the appropriate reportable cases. Passive case finding, which may be used by central registries who do not have access to the medical records, and they're relying on a hospital or another healthcare facility to report cases to them, that is considered to be passive case finding. Now, most registries do use a combination of these, and of course, every registry is a little bit different. So if a central registry or population-based registry is housed within a hospital, they may perform active case finding as well. Case sharing is an important part of case finding as well. We know that patients are not always diagnosed and treated in their area of residence where they live. They may travel for diagnosis or treatment. They do this for a lot of reasons. And this is not something unique to the Caribbean region. Right now where I'm sitting, I could get in my car and I could be in Pennsylvania in 15 minutes and New York in an hour if I drove fast. So the folks here in my area in New Jersey are, they're in Pennsylvania, they're in New York, they spend their winters this time of year, they're down in Florida. And it's really important for us to make sure that we are exchanging information with our bordering states, and in some cases, non-bordering states, to make sure, again, that we're capturing all of those. We found that, as much as 10% of our annual incident cases can come from data sharing with out-of-state registries. And I'm sure that some of you have probably experienced that or greater impact of case sharing with other registries. Again, we want to be sure that when we compare our data to another registry, that we can be certain that we're comparing equally, that we've both accessioned all of our cases. And in order to do this, we implement case sharing agreements with the registries we want to share cases with. The manual notes that there was a recommendation that in 2019, for a period of 1 year, Caribbean registries would capture data on non-residents for the purpose of evaluating case sharing. Of course, confidentiality is a big one, and I'm going to talk for the next several slides about confidentiality and security. The policies and procedures related to confidentiality are absolutely essential for protecting the privacy of the patient, but also the privacy of the facilities and the providers. They have a right to privacy as well. And it's really important that there be assurances in place that data will not be abused or misused. We, I think in the registry, are given a really important trust, and with that trust comes a responsibility, and that's what these policies and procedures are in place to do. Our staff have to be trained in the handling of
I want to write it down.
The registry staff have to be trained in the handling of confidential data and in the policies and procedures. They should review the manual periodically and make sure that they're adhering to it. Staff should also sign a confidentiality agreement. And really, for practice, it's important to re-review that periodically to make sure that we're all following the policies and procedures as they're written. So in the manual, they've provided an example of a confidentiality, security, and data use policies and procedures. So I would hope that when you're developing or maybe reviewing and modifying your own security policies, that you would look at this and look at what's included in the manual and make sure that your policy includes all of these areas. You can certainly use that as a template and adapt it to your own registry's needs. That would be a really, really great place to start if you don't have a manual at all. The manual also includes in Appendix B an example of a confidentiality agreement. We said that each employee of the registry should sign one of these. So this is a really great template. You can fill in your organization's name and have your employees sign this. Again, this manual is meant for you to use, so please feel free to take these as templates and adapt them to your own registry. So data security and physical security. Security is a little bit different from confidentiality. Security is how we go about protecting the data from misuse. We say that data in all its forms. We like to say data in motion and data at rest. Both electronic and paper have to be protected at all times. That means storing it securely and moving it securely. So when a data is stored in a database, that database needs to be protected. And then when we're moving that data, and that might mean when we're submitting it from a facility to a central registry, it may mean when we're sharing it with other registries. It might mean when we are taking a disk, a CD from one registry to another, or paper medical records, when they're being moved, they all need to be secure and protected. So, but data security also means protection from loss. If your registry is, uses paper, which many registries still do. Even here in New Jersey, we still have some paper processes. And there is a fire or flood, those papers are in danger of being lost. And the same goes for electronic information. There can be computer failures, system failures, natural disasters, all kinds of things that cause us to lose data. I think anyone who has used a computer has probably experienced a computer crash and has probably lost something that you're working on, whether it's a letter you're typing or data that you're entering. We've probably all been there. It's frustrating. Imagine the frustration at losing months or years of data collection. And it has happened. And then, of course, we always need to make sure that we ensure the secure destruction or disposal of data when the time comes. So data security. Data security are the things that we do, to protect the data using encryption or password protection. So all desktop computers, laptops, removable storage media, those are your CDs, your disks, your USB drives. They all need to be protected with some type of password or encryption software. And when your data is transmitted, again, we said it needs to be encrypted, it needs to be password protected, and you really need to keep a log of any time data leaves your registry. Physical security is exactly what it sounds like. These are the things that we create in our physical environment to protect data. These are locks and alarms on the door of your registry. This is a list of personnel who are authorized to enter that office, to make sure that you're not having physical breaches of security. And of course, locked file cabinets for anything that cannot be otherwise protected, like paper medical records, should always go into locked file cabinets at the end of the day. And, we can't stress this enough. There are all kinds of non-registry personnel who may pass through a physical registry office. That includes maybe someone coming to remove the trash can or maybe fix something in the building. And we don't want them to accidentally see paper medical records. So it's important at the end of the day that they be locked away. Backing up, we talked a little bit earlier that data security and physical security should protect data from loss, right? So it's really great practice and should be done to back up your database. We recommend that you do it at the end of the day. How you back it up, there's several options. They can be backed up to a physical device like a CD or a storage electronic external storage device like a USB. But again, that storage media needs to be protected. It needs to be secure, and it needs to be protected from loss. If you back up your database to a CD, you lock the CD in a filing cabinet at the end of the day, and some unfortunate catastrophic event happens and your building can no longer be accessed, that file cabinet is lost, you've then lost your backup. So there are other backup options for backing up off-site or to another server that should really be explored. But again, nobody wants to lose months or years of work, or even days or weeks. We work too hard to do what we do to risk losing it. And it has happened, and it is devastating when it does. And Again, covering protection from loss. We provide in the manual in Appendix C and a sample registry emergency preparedness plan. These are I think, even more important now than ever, although many of you have probably had them in place for quite some time. But I think here and elsewhere with the current pandemic situation, many of us have identified the real need to have an emergency preparedness plan, or to expand and adapt the preparedness plan that we have, because it did not cover some of the current challenges that we're facing. So these documents can and should be updated based on experience, and always kept reviewed and kept current. So the sample that is provided in the manual details the staff roles and responsibilities in any kind of emergency. Could be a weather-related emergency, a civil emergency, a fire, and of course, a global pandemic, which hopefully we will never have to deal with again in our lifetimes, but we need to be prepared in case it does. And these roles address things like protecting data security and confidentiality. Again, so important to protect that data, even in times of emergency. Preventing loss during some kind of emergency event that may destroy computers or offices or paper. We want to make sure that that data is not lost. And then ensuring continuity of operations. So making sure that we can continue to do the work that we need to do, even once when something catastrophic has happened. And these emergency preparedness plans are not just for huge events like, hurricanes or fires. They may be things here in the States. We have an emergency preparedness plan when the office has to be closed for snow. It's kind of funny. We can get 3 or 6 inches of snow and close an office, and we have to know, well, how do we continue to do our work when that happens? And then there's all the way up, obviously, to very unfortunate incidents like I believe the example in the manual is from the Louisiana Tumor Registry, and we do know that they have experienced several very unfortunate hurricanes over the years. So that is our very brief overview of the first section of the manual. I would welcome any questions or discussion or feedback that you have at this time, Sarah, if that's what we want to do.
Yes, thank you, Stephanie. That was great. Yes, at this stage, if there are any questions, there was one in the chat, and it was about whether or not a copy of the New Jersey manual is available if somebody was interested in looking at it.
Yes, it is. I can find that web address and I can put it in the chat. Let me stop sharing. And I believe it's actually been updated. There we go. How do I? Okay. I will find that web address for the manual and put it in the chat.
Perfect. If there's anybody else that has a question for Stephanie, there are a few of the people that were part of this process of developing the manual are on the call as well, so that they can feel free to answer as well. Are there any questions at this time? What I can maybe do while people think about their questions is we had a training on this manual with several registries a couple of years ago in October 2018. And when we were planning for this webinar, we thought it might be interesting to see how those registries had been able to implement implement the manual, or if they were able to do it, or if there was any progress. And I can share some of the results of that. But before I do that, Julia Rowe Porter, would you like to go ahead? You can unmute your mic.
Hi, thank you. I'm sorry if I missed it. It may be a very basic question, but it is pertaining to, the dates that are recorded in the registry in terms of when the cases are entered. It seems as if they're entered on suspicion, and then they can be confirmed later based on updated investigations. But how important is it to keep track of the entry dates as well as the dates when their diagnostic information change? And how does that work with this particular database? Because I'm asking in the context of some limitations that some of the field staff have communicated, and also in terms of my lack of experience with the database as well. So updating of each case and how that works in terms of the documentation of the updates in the registry, and how does that work?
Thank you. That's a great question. Stephanie, do you want to answer that? And just to, if you can just say which country you're from when you're asking a question. I believe it's Jamaica.
Yes, Jamaica.
Great.
So I can address a question with regard to the software. I'm wondering if there are others on the call who are more familiar with the software than I am, who could address that piece. So, with regard to the entry date, or the we refer to as diagnosis date, maybe the incident, the date of incidence. If the initial case is entered based on an ambiguous term, that's a reportable ambiguous term as listed in the ambiguous terminology list, that date should remain as the initial incidence date, regardless of whether it's later pathologically confirmed. With regard to any other changes to the information in the case, we don't typically collect those actively, although some software programs do keep logs of things that are changed. So I'm wondering if there's someone on the call who's familiar with the CanReg 5 software. I'm assuming that's the software that you're referring to. If someone can address how that works.
Yeah.
Maybe Gonzalo could answer that.
Yeah, exactly. I was going to ask Gonzalo if you'd mind. Gonzalo is a CanReg 5 expert, and Gonzalo, he's from the Azores. He runs a cancer registry in the Azores, and he's at NCI at the moment doing a fellowship, but he has many, many years experience in CanReg 5. Gonzalo, would you mind?
Hi everyone.
Thanks.
So what was the question again? Sorry.
It was about updating a record in CanReg 5, entering it when it's a probable case and then confirming it later on, I believe. Julia, is that correct?
Yes, and also the value of keeping track of the dates of updating. And I know that some cases span years and their information changes. How do we apply that to cancer surveillance and managing the data in terms of those follow-up entries? Maybe a working example of how you manage that in a database, because in the simplest form, it sounds like, they're entered on diagnosis, and that's the easiest thing to do in terms of, the cases that go into the database and how you manage them. But because many cases span years and their status changes, it gets a little more complicated in terms of managing those dates in a database or a surveillance setting.
So for the follow-up date, you have a different field. Usually, CANREC 5 is divided into 3 tables: the patient table, the tumor table, and the source table. Usually the follow-up is on the patient table, because if a patient has more than one tumor, when you update when you do an update on the follow-up, it updates all the tumors, not only the one, or not only one specific tumor. And you will only record the last updated date. So you won't get the last 5 dates that were introduced, but only the last one. That's one thing. So for the other question, I don't know exactly what's. So you can always update a record in CANREC 5. You can change the topography, morphology, whatever, and confirm afterwards. So I don't know exactly what was the issue with updating and confirming.
Right. Let me try to clarify, because I'm asking it as a novice with cancer registration, right? So you're saying you can update the tumor status separately from the patient. Is that how it works?
Yes.
In terms of
yes, you can
entry of date. Okay. All right.
Yes, you can. For example, residency. You have two variables for residency. One, when the residency at the time of diagnosis, and that doesn't change. That keeps the same. And residence and the actual residency. So the patient may move to another country or to another county or whatever, and that variable can be updated as the patient moves. But the address at the time of diagnosis, that doesn't change. So again, the address at the time of diagnosis is part of the tumor table, and the address, the actual address is part of the patient table, and that can change.
Okay.
Great, thank you, Gonzalo. Are there any other questions for Stephanie or anybody else? Jackie, go ahead.
Hi, everyone. Morning, Stephanie. Thank you so much for the presentation. I'm from the Barbados Registry. Just had a query regarding the backing up process and data storage. I noticed you'd mentioned a lot of physical storage, but how about cloud storage? How do you feel about that? And if so, what's a secure one?
Not an easy question. Yeah, so the cloud has become an option in the last few years. It's obviously more and more of us are using it. It is a great backup tool. I mean, I think everything I own is probably backed up to a cloud somewhere, even though I'm not entirely sure where that cloud exists. But with regard to confidential data, we have to be really careful because, although, for example, the cloud where the pictures from my phone are stored may be private, it's not confidential. It's not, doesn't have the protections that we want in place for our protected health information. So, it is possible, and there are organizations that do back up to the cloud. It is a good option if the cloud you're using is I'm not sure
zero knowledge
what they use there. Here we say that they have to be certified HIPAA compliant. That's our federal law that covers patient confidentiality. Now, some software, for example, Microsoft has OneDrive. You really like OneDrive. Depending on how an organization implements Microsoft, there are different modules that they can purchase and implement. So OneDrive in and of itself is not necessarily compliant for PHI, but there are ways to configure it based on how the organization implements their Microsoft account that can be made. And then again, different organizations have different comfort levels with those things. And I'll give you an example. My, in my role at the New Jersey Registry, we really had two agencies collaborating on the registry. The registry was a collaborative activity between a university and a public health department. The public health department had much more stringent rules on how to use the cloud. You could not use the cloud for anything, regardless of whether it included PHI. So I couldn't, put some documents on the cloud that I was trying to work on. Couldn't do it. The university, however, had a HIPAA compliant OneDrive account. They allowed patient information to be stored on their OneDrive account. So there's not, I'm sorry, Jackie, it's an excellent
That's okay.
question, and I wish it was easily answered, but I would look at your institution's policies if they have them, and see what solutions they can provide. But yeah, it's a complicated issue, but the cloud is certainly the direction that a lot of places are moving.
Yeah, for us, OneDrive was very difficult to make it that secured, compliant, but sync is an option that we use that we find has been very good so far, because there is a zero knowledge. So they never have our encryption keys. It's secured. It's just sometimes when you're sharing, you need to share data, it gets a little more complicated. So I was just checking to see if you had any other options, but I didn't realize you could make OneDrive HIPAA compliant. So that's good to know. Thank you, Stephanie.
You're welcome. Thanks. Great question.
Thanks, Jackie. Do we have any other questions from anyone?
If there are questions,
perhaps at this stage I can share, if there's no questions at the moment, I'm not seeing any hands up. I can just share quickly some feedback that we had. So I'll just begin here. We've done a training, as I said, for a few registries. It was pre-COVID, so it was a face-to-face training. We were all very happily in the same room together. It did take place in Maryland. Oh, I'm sorry. I think, are you hearing me okay now?
Yes, we hear you.
Yes, we're hearing you.
Hi, is everybody hearing me okay?
Yeah, we're hearing.
We hear you.
Yes, I can hear you.
Can you hear us?
Hi, I'm just testing to see if you can hear me and see my screen.
I think she might be frozen.
Yes. Oh, okay, great. Sorry.
While Sarah's getting her system straightened out, just if anyone does have additional questions afterwards, or at some future time, you can please feel free to contact any of us. I think Sarah can provide our contact information, and if we can't answer it, we'll be happy to direct you to someone who can. Sarah, are you back?
Hi, I think so. I'm sorry. Are you hearing me now?
Yes, we hear you. Can you hear us?
Yes, I'm hearing
Okay.
you fine. Okay,
Betsy, you had a question or comment?
please go
Yeah,
ahead.
I did. Maybe we'll have time for it, but I was wondering if Julia's question also had to do with keeping track of things like watchful waiting and some of the leukemias that we watch and eventually turn malignant. And I thought maybe you could address policies regarding that if we have time after Sarah's presentation.
I don't have to, I was just going to quickly present on some of the feedback, but if there are questions, that would be my preference to do that first.
Okay. You know what see what I'm getting at, Stephanie?
No, I'm not sure.
Julia mentioned that there are some cancers that sort of take years to develop. And so I wanted to comment that something like prostate cancer, where we might have a high PSA and they're undergoing watchful waiting, we won't collect information on that case until it actually turns into a cancer. So we don't really keep track of those precancerous conditions. But Stephanie, I thought there were a couple exceptions with the leukemias that I'm not that familiar with. Am I right on that or wrong?
I'm not, Jim Hofferkamp is on the call, and he might be a better one to answer that question. I think you're referring to some of the transformations, Betsy.
Right. That's what I mean.
Yeah, I think you're right. There's some hematopoietic diseases that do transfer, develop. They kind of evolve into a new histology. So yeah, those can be tricky. We've got a set of rules that we use to help us determine at what point we consider these a new primary. I'm not sure if everybody's adopted those rules or not.
Yeah, they're probably not included in the international rules. So
yeah,
yeah. So the bottom line is start tracking the patients once they have a malignancy, and there's no need to count them before.
Right. Yeah. And I think one of the earlier questions had, and I may have misunderstood the question, had to do with date of diagnosis and the use of ambiguous terminology. And I think it's important to kind of understand one of the reasons, or one of the things we're trying to track with data diagnosis is when that person first has been identified as even potentially having a malignancy. When do they first present to the medical community? When do they start planning? So if somebody comes in and they get an X-ray or something, and the physician says, "Oh, that's probably malignant," that's really the point in time that the medical community is going to start addressing that particular issue, and that's what we want to track. Now, I'm not sure of all the data items that everybody collects, but there's probably another data item that's used to identify when that tumor is pathologically confirmed or there's a definitive diagnosis. But data diagnosis, at least here in the States, really is kind of saying, hey, this is when the medical community really started getting involved with this patient for this disease.
Great. Thank you so much. That was very useful. We have time maybe just for one more question. If anybody has a question they'd like to ask before we end today.
I have a question. This is Dr. Michael Otsumba from Antigua. I have a question for Jim. The question is this here. As we get into 2021, we expect to start from January 1st with the revised morphology and topography of tumors. Is it possible for us to have a list of these new morphology and the topography for our dictionary? Thank you.
So I think you're referring to the ICD-0 3.2?
Yes, sir.
Right. Well, I know in the North States, we are adopting ICD-0 3.2 for cases, diagnosed 2021 and forward. I would imagine, and maybe somebody else could speak to this, Gonzalo or about how this is being adopted in the Caribbean registries. But it does make changes to, you know, a few changes as to what's reportable, what's not reportable. I don't think there's going to be any major changes in that regard, but there may be a few.
But Jim, we could give a link to that on.
Oh, absolutely.
It's on our website, and maybe you could put it in the chat.
Sure will.
Yes, my experience is that everything that is outside of North America, so US and Canada, it's people are registries follow whatever they follow international rules, obviously, and they will adopt sometime somewhere they will adopt the ICDO 3.2, but still there's no rule to start adopting that classification from one specific date on. But that's different from what you have here in North America. You are very strict with start using that classification from that day on. In this case, it will be January 1st, 2021. And but from my experience with other cancer registries around in other countries, that's people are not that, cancer registries are not that strict and not that well organized to decide, okay, from this date on we will use this one. It may happen in some more developed countries, like some of the European countries. But for example, in Portugal, and I still follow things in Portugal, there's still no conversation about when to implement ICDO 3.2, just to give an example.
Sure. And to be honest, most of the codes that you see, the tumors that you see on a daily basis, there's not going to be a whole lot of difference between ICDO 3.0 and ICDO. I shouldn't say a whole lot, but there are some differences. But your adenocarcinomas adenocarcinoma hasn't changed. Squamous cell carcinoma, the more common histologies are still there. Some of them have more defined subtypes. The nice thing about ICDO 3.2 is I think some of the terminology, it reflects what you'll see on more current path reports. So there may be terms in ICDO 3.2 that you don't find in ICDO 3. So it might help with the coding there.
Yes, and one other thing is that, so in Reg 5, you have the whole classification, the whole ICDO 3, and the IARC didn't update to ICDO 3.2 yet. So people using CanReg 5 right now, they can edit and they can introduce the new codes. But then the problem is with when they run the checks. So the checks are not don't consider those new codes. So IARC needs to update that in CanReg 5 with the new codes and also involving the checks as well. It's like putting the ICDO 3.2 new terms and codes in the multiple primary coding rules in
Right.
SIR, for example. So IARC needs to do that for CanReg 5 as well.
Gonzalo, do you have a timeline for that? Do you know? Has IARC
Well, no, I haven't heard from IARC, to be honest. I don't know when was the last update on CanReg 5. Sometimes it's only updates regarding bugs and things like that, and some of the graphs and things like that you can do with R and with the statistics. But regarding these updates on the classification on ICDO 3, there haven't been any in the past few years.
Okay, so I'll just make a note so that we can follow up with IARC on that, and then we can.
Yeah, that's very important thing. That's a very important thing to do.
And that really is an excellent point. I work with edits quite a bit here in the States, and if you try to use a histology code that has not yet been adopted by the registry community or has not been added to software or some of the tables that the software uses, it can cause all kinds of problems.
Yes.
So, yeah, that's an excellent point.
Excellent. Okay, well, at this stage, we are right on time. So I am going to call the meeting to a close. I would just like to thank again Stephanie, as well as Gonzalo and Jim and Betsy, everybody that has contributed to the webinar. Special thank you to our participants. Thank you for joining. As I said at the beginning, the goal of this series is really just to strengthen our community, our Caribbean Cancer Registry Network community, as well as share information that is useful and pertinent to the operation of our registries. We do plan, as this is part 1 of this series of standardizing operating procedures in cancer registries. There will be a part 2 and possibly a part 3, depending on how much we can cover at the next webinar.